Thank you very much. It's really nice to be here. Always nice to come to Rock Garden Student, and I do appreciate all the good work Courtney has done for us at the foundation over the last few years. It's been really good. A couple of starting points is, first of all, this is a little scary speech to give because there are so many people in this room who know so much. So I always rather speak, but I know more than anybody else in the room, and I'm not sure that's the case today. So I'll have to grapple with that. And then, of course, the second problem with a talk like this is that a lot of the issues around implementation, we don't know the details and can't really be sure what we're talking about. And I guess one of the fun things over the last 3-4 months, whatever, has been just getting together with people and trying to understand what this bill means and what is in this bill. So the things that and some things I think I understand real clearly. A week later, I've learned some more things, and all of a sudden, I've lost my confidence. I know them clearly. And when I go to Washington and talk to some of my friends in the administration, I realize that the same thing is happening to them. So I think we're feeling our way, so that's important. But I think an important theme to start with is that, going back, my boss at the Robert Doar Foundation, Stephen Schroeder, used to always say that implementation trumps strategy. And I think as a state, we have to take that perspective. You might like what happened with health reform, you might not like what happened in terms of its strategy and what was passed, but we do have an opportunity, and how much of an opportunity we get to take advantage of will depend on how we implement health reform. And I think the nice thing is that we're all in this together. It is a state opportunity, it's a state issue that we can look at ourselves as a community and say, how do we do it as well as possible? Okay, so here's what I'd like to cover today. If I have this right, I'm moving this open, I'm moving that to trim it right side here. I want to talk about where we are now in terms of the uninsured, and then just give a brief overview of health reform, which Courtney asked me to just do to make sure we're on the same page. Talk about the opportunities and challenges for implementation from a state perspective, and talk finally about the roles that our foundation hopes to play or is thinking about playing. I'd love to get your advice about what we should do as we go forward. So that's sort of my agenda. So where are we now? Well, we have 2.7 million people uninsured, and then we have various amounts of the insured in different programs. The largest, of course, being employer-based, which is about half of it, and then a big role for Medicaid and Medicare, but we still have these 2.7 million people who are uninsured. And when you blow that out, our best estimates are that 1.4 million of those are not eligible for Medicaid, 900,000 are eligible for Medicaid right now, but are not enrolled for one reason or the other, and 400,000, more or less, this is a hard number to get, are undocumented immigrants. And so that's the card we're dealt with right now. And it's interesting, our foundation has spent $14 million over the last 4 years trying to support efforts to lower that number, and I think that number is about the same as when we started, maybe higher than when we started, which gives you pause, but I think a lot of that, again, is because of the economy. But we've worked hard with the state pretty closely to work on those 900,000 people who are eligible for Medicaid but not covered. The state has done probably as much as it can do, the state government, to simplify enrollment, unless the federal government changes some of their rules. So, there's been progress, but there remain lots of people who are not enrolled in Medicaid even though they're eligible. The 1.4 million people who are not eligible for Medicaid, when I first came to the foundation first started, of course, the Spitzer administration was talking about doing a Massachusetts look-alike. There was a lot of attention to that. A number of our grantees worked on that, but it never quite went anywhere, partly because of politics and what happened to the Spitzer administration, and partly because of the economy, that the idea of doing a state-based and largely state-financed insurance reform just did not work out. So it's been very hard to cut away at that number over the last things. But now we have federal health reform, and clearly this becomes the largest opportunity that I've seen, and that most of us will see in our lifetime probably, to have a larger impact on coverage in New York State. Whereas some of the policies that we're working on, some of the initiatives we were working on prior to this would help get 10,000 people covered, or 50,000 people covered, or maybe 100,000 people covered. Now we can think in terms of the millions, and it's sort of a whole new ballgame. It also turns out that it's a ripe opportunity to address our objectives as a state in cost and quality. And as Courtney hinted, like the bill is constructed as a coverage bill, but there are lots of bells and whistles that are about trying different efforts of cost containment, trying to improve quality, and trying to improve access. So there are lots of opportunities that we need to take advantage of the state. And I think a lot of these opportunities we'll get to are going to be competitive opportunities where the issue is, can we get our fair share or better of those resources? So what are some of these provisions? I think a lot of you know this, but I'll just make sure we're on the same page here. Very importantly, there's this whole set of interrelated elements that really should encourage greater coverage. And first, it requires the United States citizens and legal residents to have a qualifying health coverage, assuming that it's affordable. And for most people, it should be affordable, we think. So it has a mandate. And then secondly, there is some employer responsibility. If employers with over 50 workers don't provide coverage, they will have a penalty, not a very large penalty, but a symbolic one. And then, of course, it establishes state health exchanges, which is a way that people between 133%, perhaps, and that we'll see exactly where that works, but perhaps in most states between 133% and 400% of poverty will be able to purchase policies, either their own or through a small employer. So this will be the direct market in some ways. And there are pretty substantial subsidies that get smaller as you get closer to 400% of poverty to help people pay for that coverage. And then, of course, the bill expands Medicaid coverage, although in New York State, we find out that it doesn't really expand Medicaid coverage very much, and I'll get to a number that is our estimate of what it will expand. But we are more generous than a typical state, and so raising the coverage levels to 133% just does not affect us so much. So these are some key provisions. Of course, the last one related to coverage is that it will force us to look at our commercial insurance markets and regulations about that. It has some substantial, complicated changes in how insurance is regulated in this state. That, again, will be a big implementation question. There are some premium rate reviews, some risk pools, some medical loss issues. It'll allow a merge of the individual and small group market that a lot of us have been talking about for a couple of years. It takes away lifetime maximums and annual maximums, and importantly, it sets services that can be mandated. And if you go beyond certain services that the feds say have to be in exchange policies, the state would have to pay with state dollars for those services. And we'll see how that really plays out, but sort of things like even some home health care could be that what we mandate right now is more generous than the federal law says it should be. And in order to keep it affordable, the feds are saying you need to take that out of being a mandate, or you need to pay for it with state dollars. So that gets very complex for us, and there's a whole range of mandates that are like that that would have to come out. So figuring out how to deal with that truly will be an important issue. It also expands primary care access. There are literally billions of dollars nationally to expand community health centers and other forms of access. These are the bells and whistles part of the law that are quiet but important. And there is money to stimulate delivery system reform demonstrations in both Medicare and Medicaid. And some of those are geared towards cost reduction, some of those towards quality or value or prevention, a whole series of activities. So there's a lot there. Now, I like to think in terms of, when you think about strategy for implementation and sort of where do we want to get to, I like to think of these buckets of people. And this is one way of looking at the 2.7 million uninsured. And, these numbers aren't right to the last decimal point, and that's why we round them up here. But these are, I think, about right as we look at it. There are currently, as we think, 900,000 people who are eligible for Medicaid but not enrolled. There will be 100,000 people who used to be part of that 2.7 million that will become eligible for Medicaid in New York. It's a very small number, but that's because, again, we're we're at the 133 or above mark already, except for a few specific populations that are not very big. So our Medicaid expansion is at most 100,000 in our estimates. We have approximately 400,000 undocumented, and these are the one group we know will probably not change, so I can fill in that. There's people income eligible for exchange subsidies, and again, we've worked at this, and we think the right estimate is there's about 1 million people who are currently uninsured who will be eligible for subsidies in the exchange. That's a big number. It's not as quite as big a number as I might have thought, because there's still 300,000 people who will be income eligible, either because the subsidy isn't big enough for them to afford it based on the guidelines in the legislation, or these will be people who just decide not to take the exchange subsidies and opt out and pay the penalty. And so we've made some estimates of that, and we think that's 300,000. Well, in some ways, our implementation challenge on the coverage side is to get those numbers that become insured post-reform as big as possible. And I think these are the right buckets of thinking that. How are we going to get as many people who are eligible now for Medicaid and not enrolled? And we have to figure out how to make that a big number. You know, unless the feds do a lot, I don't think that will be a big number. I don't see a lot in the legislation that will, really push that number. And I mean, I think it'll be a couple 100,000. It will not be 700,000 come forward. That's our guess. The newly eligible for Medicaid, I would hope that most of those would actually enroll, but we know that not everybody enrolls, and so that'll be some percentage. I hope a percentage a lot more than 50%, but it's not a real big number. As I said, the undocumented, we know it's not going to change. The income eligible for exchange subsidies, our sense is that most of those, or a large percentage of those, will enroll, and all the simulations that the Urban Institute and CBO is doing are suggesting that most, not most, but 70, 80, some large percentage of them. But how we implement the exchanges will partly determine how many of those folks actually enroll. And then the income ineligible for Medicaid, or the people who are going to either opt out or not be affordable, again, that will probably be a pretty large chunk of that 300,000. We don't know how many, and again, what we do on implementation could really affect that number. So again, I think our challenge is to get that middle column to have as large a set of numbers in them as possible. Two emerging themes. It will take good implementation to get coverage up. And the second is there will still be many people left behind. If I had to guess, coming back to this slide, if I had to guess, I know this other point, I don't think that number will be 1.35 even. I mean, I think that would be less than 50%. It surely will not be 70% to 2.7. So we're still going to have a relatively big number in the uninsured column. I'd suggest at least half of that 2.7. Again, we're working on getting estimates of these. So that suggests that coming across here is that we're still going to have many people left behind. So part of our implementation challenge has to be, how are we going to take care of the safety net? And how do we feel about that safety net? I mean, coming back here, do we feel the same about everybody in that middle column, or do we not care about the people who opt out, or do we not care about the undocumented? I hope not. But sort of, we have to think about our relative sense of where we invest and how we invest in the safety net. The other emerging themes that I think are important is that more people will be seeking primary care. If we have 1.5 million or 1 million people more covered, that does have an effect on demand, and we know that in Massachusetts that was an issue, so we have to be ready for more demand. And finally, we know that if we don't manage costs, this is all going to fall apart on affordability grounds. More people will opt out because of affordability, and the state will become that much more challenged and has to pay for all this. Okay, we also know that the states are key to the success of federal reform. It's the state government that has been charged with expanding Medicaid. It's the state government that's been charged with doing something to get the exchanges up and running. So they have a major role. They're not the only ones that have a role. I think that all providers have a role, insurers have a role, payers have a role, consumers have an important role. So I think there are other people who need to be at that table, but the state government is assigned some of the more challenging aspects of this. It's a 4-year implementation schedule. with the major provisions going to happen in 2014 and the major impacts expected by 2019. Now, I'm not going to go through these, but I just want to show you this long list of things of what has to happen each year, and I can put these slides on your website if you want. But we have contracted with Manat Phelps to do a real roadmap for the state, and they've been working closely with the Department of Health folks and Department of Insurance folks, saying what are all the steps that have to be done in New York, and who has responsibility for doing them, or what will it take. So we hope to be publishing in the next month or two a real detailed roadmap of all the decisions and activities that have to happen. But these are the lists in 2010, there's a list in 2011, a list in 2012 and 13, and then a very long list for 2014 where the exchanges have to be up and running, Medicaid expansion has to be in place, and so on. So this is a timed intervention, and we know that a lot of folks have been working on the high-risk pool, which is one of the first things to go, and there's a lot of others that are happening even this year. Okay, implementation opportunities and challenges. What do we as New Yorkers have to do to make sure this happens well? Let's start with some reality checks here, which is scary. The first thing is that so far the reform has not provided major funding for implementation. I mean, think about the fact that Massachusetts spent as much as $25 million to get their exchange up and running. There isn't money like that in the federal legislation. There surely isn't lots of money in the state government these days to do that. So we don't expect to see huge amounts of money come forward from Washington for implementation. The federal budget deficits, are getting in the way. Surely the Republicans are fighting tooth and nail not to expand any more spending, and there's elections coming up. The other reality check is that New York will continue to face its budget challenges that it's facing, which makes it hard for affordability. The state has both resource and personnel constraints, and we've seen good people leave state government in large numbers and not necessarily get replaced, so that's a challenge for those who are left. And of course, we have a gubernatorial transition, which makes activity in the next 6 months rather complex. And so what should the current administration do? What should the next administration do? Who's going to be the next administration? So it's a funny time that we're in. Okay, if we look at what has to happen and some of the challenges, the state first has to worry about expanding coverage and enrollment. So these are the core element, and they must set up the exchanges. There are a ton of issues that have to be decided about these exchanges. A lot of us were talking about it in the hallway before it started. How many exchanges? How do you connect consumers to the continuum coverage? I think that one of the huge challenges we're going to face is the transition issue. If you have somebody goes from 100% of poverty to 150% of poverty, which happens a lot, you lose your part-time job, your spouse loses their job at Walmart, you're going to go from Medicaid at 100% of poverty, theoretically, to the exchange at 150% of poverty. And so you have to apply all over, and then if you lose the job, you have to apply for Medicaid all over. How are we going to deal with the transitions in and out of these programs? And again, we haven't gotten enough guidance, I think, from Washington, but we're going to have important issues on that. The second is, should the state create standardized plans for low-income people in lieu of commercial coverage? That is something called the Basic Health Plan, and it's very complicated. Details are being worked out. But you can take people who are between 133 and 200% of poverty, create a basic health plan, cash out what their subsidies would have been, and then provide coverage to them in a basic plan. That might be the best approach for creating more seamlessness, at least for people under 200% of poverty. But we have to decide, do we want to do that? How do we do it? What do we do about Family Health Plus and Healthy New York? Healthy New York is probably not a qualified plan. I don't think probably it's not a qualified plan unless it gets an exemption under what is considered the bare minimum plan of feds. So all of these are implementation questions that we need to address. And then, of course, we have to deal with the insurance market reforms. We have to enforce the prohibitions on lifetime and annual benefits. We We have to decide if we want to merge the individual and group markets, big decisions. We have to decide what we do about these services that are currently mandated, but if we want them mandated in the future, we'll have to pay for them with state dollars. And that's just the tip of the iceberg. There are, lots of questions about how we do insurance reform. Of course, we don't even have it as difficult as other states because at least we have community rating. We have a lot of the features that are in there already, but it's still complicated. Now, the second, so those are the challenges around expanding coverage. But then there's the issue of how do we ensure access to care? It's worthless to have coverage if you don't have access. And here we think, again, Massachusetts instructs us we have to worry about this. First thing is that, as I said, perhaps at least 1.5 million people will remain uninsured. We need a safety net that works for that coverage. We need an affordable safety net. And so I think that we need to take advantage of everything in the bill to expand community health centers, to make our community health centers as viable and as healthy as possible. And there's a lot of money that is flowing. There's $11 billion nationally to support community health center expansions. Some of that money is on the table right now for an RFP that's on the street. It's competitive across states, so we really need to figure out how New York gets its share. Our foundation is actually hosting a meeting next week on this question, and I know some of you will be attending that. But that's a very important issue. There's also $7 billion on the table for prevention, wellness, and public health activities. As a state, I think we have to figure out how do we get our share of that, and how do we use that money to really make a difference on prevention and costs and value and all those. There's a 5-state demonstration to test altering payments from fee-for-service to capitated global payments. Do we want to be one of those 5 states? How do we go about competing to be one of those 5 states? And I think that involves more than just the state government. It probably would involve payers and providers. We have to think about that. There's enhanced funding for medical homes. How do we make sure we get that done as well as possible? So this is all a long to-do list that isn't even about coverage. It's about the improving access to care. Then we move along, and there's the delivery system and containing cost features of the bill. On this one, we know that if we don't hold down costs, as I said, we're going to be in trouble. And so what are the opportunities on the cost side and the delivery system side? Well, there's a whole series of demonstrations that will look at broad delivery system reform. There's issues around integrating benefits for Medicare and Medicaid dual eligibles. Dual eligibles cost a great deal of money. People are eligible for both Medicare and Medicaid in our state. If we could begin to take advantage of some of those demonstration dollars, we perhaps really could transform how we manage those folks, give them better care at a lower cost. Have to figure out how to get that done. There's federal funding for a whole series of demonstrations, from accountable care organizations to reducing readmissions, and all of those, again, we want to figure out how, we as a state want to figure out how to take advantage of them as much as possible. Okay, the role of our foundation, just thinking about what should we do to help. I think most of you know our background. We sort of received money when Blue Cross went for profit, and more or less received about $300 million. We make $15 to $20 million in grants a year with that money, focused on the issues as were laid out. And so what can we be helpful? Well, we think we can be a facilitator. We could bring groups together, whether it's the state government, local government, insurers, employers, the consumers, and sort of make sure that people are being heard and we're designing this together. We can offer resources. We've been making about $5 million a year of grants on the coverage and cost issue. We expect to continue that, if not increase that, because we see this as the moment for making progress in coverage, as I said earlier. And I think we could be a party that is really, nobody's pure in this world, but we don't really have a dog in this fight. We're really interested in outcomes and practical help. We don't have a political bent, and we don't have money to be made or lost. So I think we can play the role of somebody who's interested in outcomes and practical help, and how can we do that? So that's sort of a vision, at least. What have we done so far? Well, we've really been consulting with stakeholders. We've been holding a series of meetings with the governments, with payers, we're going to do community health centers next week. So we're really trying to get a lay of the land. We've been, again, meeting with state officials and other policy officials. We've been really trying to understand what other funders like ourselves and some of the national foundations are doing in their states, so we can learn what are the opportunities. As I said, we've funded this roadmap that Manat is doing that will really be a guide, we think, for all of us. We do have this issue of working with government that need to put on the table, is that we cannot supplant government. I mean, our board really feels that we need to be a partner, and we have to supplement what government does. We can't be a substitute for it. And so we look for opportunities that follow that principle. And of course, we say that because if we just substituted for government and started to pay for government employees or whatever, our money would disappear very quickly because we're so small relative to the size of the government. So we really look for leveraged opportunities. We look for opportunities that are partnership types of things. Here are likely strategies. Here's the things we've been talking about with our board. We've been talking about really establishing a set of activities that are discrete but interrelated around each of these elements of reform: expanding coverage, improving access, worrying about the left behind, and improving the system cost value prevention on those areas. We want to fund efforts that assist both the state government and the full range of other actors out there trying to improve the health of New Yorkers. As I said, I've really covered that. Let me talk just a little bit about the coverage expansion. Our sense is that there's a lot of analysis that needs to be done about what are the implications of doing it this way versus that way. And there's a lot of technical assistance involved. There's a whole series of questions. And I think there's a fair amount of convening involved. So we're looking for analytic contributions, technical assistance contributions, and convening contributions. Importantly, though, we have to figure out where we are wanted as a funder. To the extent that some of these decisions will be made politically or be made, for other reasons, we don't need to be at that table. To the extent that people feel like they want to look at options and compare pros and cons, we can help fund those activities. On the access side, I think this is where it gets bigger than state government. We really, as I've said earlier, we would, and the state needs to in general, but we really want to work with community health centers to get access to those federal funds. We'd like to see New York be one of the states that gets the safety net hospital payment reform demonstrations. We think that will be essential to keeping our safety net hospitals in the lead and viable. We would like to help on the primary care medical home model, getting as many of those resources in place. That also works towards our diabetes interests, because it's all part of that. And the whole dual eligible issue, I think, is one where if we can be helpful, that would be great. On the cost containment, again, there's money out there in the bill for all of these activities: accountable care organizations, payment reforms, coordinated care for Medicare and Medicaid, as we just mentioned, civil tort reform, wellness programs, encouraging community-based long-term care. To the extent, there has to be lots of players in this, but to the extent there are opportunities to bring people together to say, how do we get those federal resources that are at stake, we would like to be helpful. So I will end there.